Sound check, sound check. Hi, folks. Professor Gulliford here. Just want to do a recording of the content that we did not get through on our Monday meeting. It won't take very long, I don't think. And uh, and then you can go ahead and do those cases. I see that a few of you went ahead and did the cases, and that's awesome. If you could find the material you need, then just go for it. But I'll go ahead and record the PowerPoints now, be the second half of Chapter 6 and Chapter 7, and then I'll post these in the course. So we're screen sharing, and we should be able to call up. Here we go. Let's make sure this is, in fact, Chapter 6. It is clearing the airways. And here we go. Epithelial lining of the airway. When foreign particles enter, and they will always enter, especially if you're in a dusty environment, there will always be, a certain amount of stuff just kind of blowing around in the wind, and it does get to your lungs. So nature has provided a way to protect us, the alveolar macrophage. It's the white cell of the respiratory system, and they just exist in the alveoli. And when something gets down there, let's just say a bacteria that shouldn't be there, the macrophage attacks and kills that bacteria. Now, if there's way too much bacteria, it may not be able to keep up, and that's where we wind up with an actual infection that shows up on the X-ray as consolidation. Let me get that word in your vocabulary. Consolidation, which is pneumonia. Here's a little picture of what's going on. We have particles that make it quite a ways down into the airway. Larger particles are filtered out upper, higher in the system. Let's make that bigger for you. Higher in the system, but the smaller particles can really go a long way down and could cause problems, pneumonia, deposition of aerosol. That's important to us. We want the aerosol to deposit when we're giving a breathing treatment. We want the particles to be the right size to get well down into the lungs to the level of the bronchioles where they can really do a lot of good. I think this was intended, this picture right here, to show you what the Trendelenburg position is. That's head down, legs up. We would put the patient in this position to help with drainage of secretions from the lungs. Let's say they've got a lower lobe pneumonia. You might put them in this position. That's a little extreme, I would have to say. Typically, we raise the foot of the bed 18 inches. That might be worth jotting down. Typically, raise the foot of the bed 18 inches and leave the head of the bed where it's at. But the idea is to use gravity to help. Phagocytosis, that's the process of the macrophage grabbing the bacteria, and it works for most pathogens that come into the alveoli. However, some bacteria, like tuberculosis, TB, are ingested by the macrophage, but the enzymes are not able to kill them. That's why it is a long process to recover from tuberculosis. So what the macrophage will do is encapsulate and contain the infection, which creates, might be the first time you're hearing this word, cavitation. Cavitation. There is a cavity on the X-ray, usually an upper lobe cavity that forms and seals off the infection as best it can. But that is an example. This is why the patient needs to be on 4 antibiotics for 6 months to 1 year. Those antibiotics are rifampin. You don't have to memorize these yet. It's just the first course. Rifampin, isoniazid, pyrazinamide, and ethambutol. It spells ripe. But they have to be on that for 6 months or even a year. Yeah. So this is what happens with tuberculosis. We're kind of sealing off, trying to seal off the infection, but we're not able to kill it. If that bug were strep or staph or any other common bacteria, the macrophage would just kill it, but it can't do that with tuberculosis. And that's why it's been such a bad disease over the years. Tuberculosis back in biblical times wiped out whole cities. It just spread quickly through the city and just wiped it out. We can do better than that today, but it's still You know what the real problem is? The patient feels better after the first, let's say, week or two of antibiotics, but they're not better, and the bacteria is still alive in there. So we've got to get them to do it for 6 months or even a whole year. Pneumoconiosis is really any kind of inhaled disease. Coal dust, coal workers' black lung is a famous example of this, but any kind of a dust that's inhaled into the lungs and produces damage is a pneumoconiosis. Yeah. Coal dust, black lung disease would be a good example. It's a type of pulmonary fibrosis, which is another new term to get in your world. Pulmonary fibrosis is any scarring of the lung due to insult from something from the outside. Silicosis, that's silica that's inhaled into the lungs and produces a similar kind of problem to what you would have with black lung disease, coal miner's lung. Asbestosis, if you search asbestosis today, what you get are mostly lawyers' websites, not medical information. And that's because of people suing the company they were working for when they inhaled the asbestos. We didn't know. Asbestos was an amazing invention back in the 1950s because it didn't burn. You could make shingles out of it and the house would not burn. We even made pajamas for kids out of it because we thought that would protect them in a fire. But the problem is those asbestos fibers are inhaled, and once they're in your lung, they don't come out. So it's a bad problem. And this is, I'm sure you've seen the TV commercials for mesothelioma, the cancer, which is caused by asbestos. And it is legitimate. I mean, it is a serious cancer, but people getting rich over that are definitely lawyers at this point. So we got asbestosis, we got mesothelioma, mesothelioma, get it right. Hypersensitivity pneumonitis. This is inhalation of fungal spores, often related to bird droppings. If you have, by any chance, anyone you know who is a bird fancier, they have some pet birds in the house, they have to be very careful because they may inhale these fungal spores from the birds, from the bird poop, we could even say, right? Um, Also, if you know someone who works in chicken or egg production facilities, they have to be very careful of this. They can inhale the fungus and wind up with a serious lung disease. Occupational lung diseases are real. There's certain things inhaled in the workplace, occupational asthma, it's called. Um, and the number of years of exposure and the intensity of the exposure determines how severe. That's probably enough on that right now. Irritant reduced induced asthma, reactive airways dysfunction syndrome. Some irritant is causing the reaction in the patient's lungs. One that I'll mention is cold air. Some of our patients, just as soon as they breathe cold air, they go into bronchospasm. But there are lots of other things. Oh, hairspray. I have a patient who's a hairstylist and breathes a lot of hairspray. And she definitely has an irritant-induced asthma, in spite of her best efforts to reduce the exposure. Thickness of the secretions is all about hydration. Viscosity means thickness, so the thickness determines how well our lungs can clear the offending organism or whatever the particle is. Humidity, normal heat moisture exchange. This goes by the chloride sodium channels of the body. But hydration, one of the best things you can do for your patient, just push that water pitcher to them and say, are you drinking enough water? It really makes a difference. We're trying to shoot for an absolute humidity that is sufficient for the lungs to move secretions easily. The relative humidity is a percentage, and I want to put this number in your head, 43%. We know that if we can keep the relative humidity where you're living, the room that you're sleeping in, the room that you're spending most of your time in, if we can keep that at 43%, then your lungs are going to be in much better shape. And viruses hate that. Viruses don't live well at above 43% humidity. So that's what we're trying to do. If you don't have a humidifier in your own sleep area, in your own living room, let's say, you really ought to. Yeah. The little gauge that measures humidity is $9. I looked it up the other day at Walmart, but it's very helpful to know what the humidity is in the area that you're spending most of your time. Simple formula, it's the content of water in the air divided by the capacity of the air to hold water times 100%. We're shooting for 43. Humidity and hydration, 100% relative humidity means that the air cannot hold any more water. 40% means 40% of the water vapor it could potentially hold. 40 is getting close. We would like 43. That's why why hot, humid days feel muggy. Yeah. Second mechanism for supplying hydration is the nose and airways. Your nose does a remarkable job of humidifying the air as it comes in. We can normally get up to about a 50% with just the function of the nose. But sometimes the mucous membrane is being dried out as your nose is doing that. So let's help the nose. Let's make it easier for the nose by having 43% humidity in the air. Yeah. All right. Isothermic saturation boundary. This is a point about 5 centimeters below the carina, and this is where air reaches normal body temperature and relative humidity. So it is remarkable how your lungs will do this. Now, one of the reasons I ask you guys about mouth breathing is that if you're breathing through your mouth, this function does not work nearly as well. This is why we need to get our patients to be able to breathe through their nose, even if that requires some surgical intervention. If there are polyps or deviated septum or something that won't let the patient breathe through their nose, we need to fix that. Okay. Body's also capable of supplying some hydration through chloride sodium channels, but let's not depend on that. Let's give the patient enough humidification so that it is easy for the body to keep up with that. Now, the CFTR, this is a new board exam question, which just came up this year. It is a mutation that causes cystic fibrosis and results in thick, sticky secretions. It's a genetic disease. We'll tell you all about it when we get to that disease course, which is a fun course to teach. It's really interesting. But what we got to do with the cystic fibrosis patient is try to replace that mutation impact. There's an enzyme called pancreatic dornase, that is missing in cystic fibrosis patients. So we give it to them. You will see it at the hospital very soon during your clinicals. It's called Pulmozyme, or sometimes just called DNASE for short, DNASE. But Pulmozyme replaces, to some extent, not perfectly, but replaces some of that missing enzyme. And then the cough reflex, the cough reflex is there for a reason. When you cough, it's because something needs to move up out of your lungs. Very important. Cough reflex begins with the vagus nerve. How many times have we mentioned that vagus nerve so far? It's the wanderer. It goes to all these different places in the body. And the cough center in the brain, and what you do is you close your vocal cords, build up pressure, and then release it all at once, generating a cough. Okay, the body's airway clearance mechanisms, if we will let them do a good job, they move the mucus up the airway. But then what happens is people do things like smoke cigarettes, allow the air in their house to be way too dry. The mucus can be very thick and hard to move. Eventually, it does actually solidify. Sometimes we'll see an area of the lung that's completely blocked by solid mucus. It's called a plug or a cast, and it may not allow the patient to breathe in that area at all. So deep breathing and coughing, we recommend that. You're going to utilize a thing called an incentive spirometer. It's sort of a respiratory exercise device, and that incentive spirometer will help the patient to take deep breaths and get the secretions out. Manually assisted cough, also known as quad cough, that's what you'll hear at the hospital, is where we actually help the patient cough by using our hands. We'll show you a picture of that before you do it at the hospital, but you're assisting the patient who can't generate a good cough on their own. Maybe they have partially paralyzed from trauma, or maybe they have very weak muscles like muscular dystrophy or something like that. But quad cough, yeah, very, very useful technique. You'll be doing that soon. And postural drainage. This is, we're just going to quickly show you the positions. Don't try to memorize these, because all you have to do is put the area that you're draining highest. The area that we're trying to drain gets highest. Let's just say the patient has a right lower lobe pneumonia. You would put them on their left side with their feet elevated, head down. And typically it's either 12 or 18 inches that we elevate the foot of the bed. Modern hospital beds are amazing for that. It's so easy to just put them in the position you need. There you go, postural drainage. You'll have patients in all of those positions. There's the Trendelenburg, which is just legs up, head down. And there is a reverse Trendelenburg where we actually put the individual's head up and feet down. We don't use that one nearly as much, but Trendelenburg we use a lot. And then you do need to know that just upright seated in bed is called Fowler's position. Fowler's position. Trendelenburg, head down, feet up. Reverse Trendelenburg, head up, feet down. And then Fowler's is seated upright in bed. Postural drainage combined with chest physical therapy, which sometimes we do these days with a vest system, a vest, or a manual percussor. They, both work pretty well. I'm a big vest fan myself. I think the vest is amazing. There's an awesome little video. I think that would be worth taking a minute to see if I can find that for you. Try not to get lost here. If I can't find it pretty quickly, then we'll move on, but I'd love to show you. Oh, no, that one won't work. That's a pretty good one. Yay. Notice how the vest is shaking her up. She actually enjoys it. At first, she thought it was kind of funny, but then for several weeks, it scared her. It does get going pretty fast, but they get used to it. And after 3 months, she still doesn't love it, but she's adapted to it. And what it's doing is loosening up the secretions in her lungs so that she can breathe. It's just awesome, actually. Twice a day, usually 20 minutes morning, 20 minutes evening. And there we go. Positive pressure therapy sometimes also used. We use a handheld vibratory device called oscillatory positive expiratory pressure. We got lots of tricks that you'll learn to loosen up these secretions and get them out for patients. The vest, I'm just going to add that here. The word vest is a brand name of the Hillrom company. So what you'll see on your test is high frequency chest wall compression. High frequency chest wall compression. But you'll never hear that at the hospital. We don't have time for that. It's just the vest. It's just the vest. Aerosol therapy, intrapulmonary percussive therapy, they all help. We're just trying to loosen up the secretions and move them out of the patient's lungs. When there is a consolidation, you hear what's called bronchial or tracheal breath sounds. Those always appear over the major airways, but if you hear that out in the lungs, out in the periphery of the lungs, then that's a problem. That probably means pneumonia. Okay. That really has already been covered. Oh, crackles. Yeah, crackles are the sound of pneumonia, coarse crackles. But I want to mention this word rales, R-A-L-E-S. You'll hear people say rails, but it's actually rales. And that was the original name for crackles. So when you hear that, it's just somebody who was trained long ago, and they're talking about crackles, which go with pneumonia if they're coarse, congestive heart failure if they're fine. I think that might be worth adding right there. The fine crackles, congestive heart failure. The coarse crackles, pneumonia. There we go. Rhonchi, these are secretions in the airways. They make a deeper rumbling kind of sound. I would say gurgling type of sound. And what you need to know for board exams is that the rhonchi clear when the patient coughs. The patient can cough, move the secretions, and the rhonchi go away. None of these other sounds go away with a cough. So um, let's see, goes away with strong cough. I'll just add that, and you got one more point right on your board exams. Wheezes, those are the problems of narrowing, constriction of the airway. And the number one disease, of course, for that is asthma, the number one thing that causes wheezing. Now, a foreign body will also cause it, and a tumor will also cause it. So here we go, is a really good picture of the different breath sounds and where you will hear them. Now, you've got a whole patient assessment course coming up that is going to go into much more detail. But every sound I just talked about is here, and it shows you where they're most likely to happen. Almost done with chapter 6, folks. Thanks for your patience. It's the summary. We breathe about 10,000 liters of air every day. Wow. That's a lot of air in and out. Our lungs do an amazing job of protecting themselves, but sometimes they need our help. They definitely need our help with things like tuberculosis and cystic fibrosis, whenever the secretions get too thick. So system works well, but it's not perfect. Goblet cells produce the mucus. If you see an increase in the number and size of the goblet cells, something's causing that, and it's probably inflammation. And let's see here, the mucociliary escalator gets the secretions up to the level where we can cough them out. And then the macrophage does its remarkable job down in the alveolus, capturing and killing bacteria. Just a miracle in nature, I believe. It's amazing. When the mucus clearing system gets overwhelmed, secretions build up. That's like cystic fibrosis. Or maybe you're a post-operative patient who's in too much pain to cough very well. And then we use our bag of tricks. And here's the bag of tricks right there. Everything we just mentioned, I won't read them to you again. So that concludes chapter 6. And let me see if I can easily find chapter 7 here. Oh, wait a minute. That was chapter 7. What we just finished was chapter 7. So what we're moving on to now is chapter 8, and then we'll be caught up. My apology, folks. That was chapter 7 that we were wrapping up. Chapter 8, pulmonary hemodynamics. That is, hemo is blood, and dynamics is the flow of blood. There are 74. Oh my gosh. That will need to be a separate recording. I don't have, honestly, I don't have time right now to record chapter 8, but I will. So for now, we've caught up with chapter 7. And let's see here. I will just end this recording. And put it in the course. I'll back to you probably later today that I can get the chapter 8 recorded.